Thank you, Dr. Sebeth. And thank you so much for having me today. This is a great opportunity because as we go forward into curriculum renewal, it's going to be absolutely essential that pathology and lab medicine work together so that we can make everything go the way it is supposed to. So today I'm going to talk about curriculum renewal, which is set to start in 2015, or this year. And I'll go through the nuts and bolts about it, the why, the how, and the when. But the thing I really want to focus on is what we, meaning pathology and lab medicine together, need to do about it. So I want to warn you in advance that there is some active participation in this talk. So as we're going through this, what I want to hear from you guys is additional ideas. I'm going to talk about ideas I've come up with how to keep pathology and lab medicine really visible, but I want to know what your ideas are too. And if you don't want to talk about them in this form, I want you to talk to me about them later because we need to make sure this all gets included in the curriculum. So why are we doing curriculum renewal? And this is a question that's come up a lot because as many of you have probably seen emails flying back and forth, an enormous amount of resources have been poured into this. Well, the reason we're going through a curriculum renewal right now is in the 55 years history of the UW School of Medicine, we've really only done a serious look at our curriculum 3 times, which is not too many. So in the late 1960s, they did a curriculum renewal, and that is when they really switched to an organ-based teaching approach to this, where you learn about the cardiovascular system and its organs all together. So that was the first major development. In the early 1980s, again, there was a big re-look at the curriculum. At this point, there was a real emphasis on changes in the clinical education, which I'm not really going to go into much, but they are, have stood the test of time since then. And then the last time the curriculum was really looked at was in this period between 1998 and 2001. And while some minor tweaks were made to the actual content and the way material was delivered, the main thing that came out of that renewal process was developing the college system, which I'll talk a little bit about later, but really increasing mentoring for our medical students and making sure that medical students got early access to the clinic. So that's really the big changes that have happened so far. So before we start talking about how the curriculum is going to change, I know some of you know quite a bit about the medical school curriculum and probably others of you don't. I know this is difficult to read, so I will walk you through it. The first year curriculum now is your typical basic science curriculum that I think many of us took in medical school, where you start with anatomy, embryology, histology, normal things, immunology, biochemistry. Then it kind of moves on to the nervous system, musculoskeletal system, microbiology. And then you'll see there's this introduction to clinical medicine, as well as MIDM, which is medical informatics and decision making. So these are courses that our first years take right now. But most of that is all normal. Then you go on to the second year where you learn about abnormal. And so most of the second year is currently a systems-based curriculum. So it starts off for the first 2 weeks with a crash course in both pathology and pharmacology. So this is where we teach what is the inflammatory response? What is wound healing? Very basic things in pathology. Same with basic principles of pharmacology at the same time. Then we dive into a systems-based approach, starting with the urinary system, cardiovascular system, respiratory system. And the systems courses march along, and pathology and pharmacology kind of march along with them for the most part. Everything doesn't match up perfectly, but it does pretty well. So that's a full 2 years of basic sciences. Then our medical students go off to third year and they do the 6 core clerkships, which would be medicine, surgery, pediatrics, family medicine, psychiatry, and OBGYN, very similar to what many of us probably did. And then in fourth year, they have a couple requirements, one of them being emergency medicine, and then they have time for electives, time to do step 2 board preparation, time to do residency interviews, and then at the very end there's this capstone course where they kind of try to put everything together before we send off our graduates to start practicing medicine. So does this curriculum work? Yes. Is it a good curriculum? Yes, we've had much success with it. Okay, so we are not undergoing renewal necessarily because there's something terribly wrong with our current curriculum. One of the things that has become a problem for this curriculum is when our medical students have to choose their career path. So I have drawn this red line here. That is the point at which a medical student's dean letter gets submitted. So they have to know which program they're applying to, they have to have done their sub-I or elective in that, and they have to be ready to go. What you will notice is these are all required requirements. There's very little time for electives. So if you wanted to go into pathology, for example, or radiology, you'd really have to know that way ahead of time and right immediately as soon as you started fourth year dive into that. And that has become a problem for a lot of our medical students. And we've seen an increasing trend of medical students taking 5 years to get through medical school simply because they need to expand that fourth year into 2 years to give them time to try out ENT, then to try out palliative care, and then finally settle on hopefully pathology. All right, how is this currently taught? This curriculum takes place both here in Seattle and in the WWAMI region. So WWAMI, for those of you that don't know, stands for Washington, Wyoming, Alaska, Montana, Idaho. So it's a 5-state alliance that basically the core medical school is here at the University of Washington, but then we have these regional sites that do a significant amount of the teaching. So what normally happens is in first year, our medical students are spread out all across the WWAMI region. So we will have about half of all of the medical students here in Seattle, so 100 or so. Then we will have medical students in Spokane, we'll have them in Idaho, Alaska, Montana, and Wyoming, okay? And so at each of these sites, we are partnered with another university to help teach the basic sciences. Thus far, that has been one of the strengths of our program, and I'll get back to that in a little bit. Currently, in second year, all students from the whole region come to Seattle then. For at least 1 year, they're here. So we have all 220, however many there are, here in Seattle. In the last 2 years, that has been different because we've had some in Spokane. But for the most part, we've had most of the students come back here. This is a point that will be a major change in the new curriculum, which I'll talk to. Then in third and fourth year, the students have options all over the entire region. And if you can see this map, each one of those dots is a place where there's a WWAMI site where a student can do a clerkship, an elective, something like that. It gives our students an incredible opportunity to see what rural Montana practice is like, and then their very next rotation can be at Harborview. So it's been a wonderful experience for that. So in 2010, Dean Ramsey said it is time to reevaluate our curriculum and take a serious look at this. At the same time, medical schools across the country, it became the fad to do this. I'll be honest, everyone started doing this at once. But Dean Ramsey had specific things that he wanted us the whole faculty, to come up with when they came up with a new curriculum. He wanted to expand the physician workforce. So as many of you know, we have a severe, primarily primary care workforce shortage here in Washington and there are other rural states that we're partnered with. So one way to do that is increase the number of medical students. But even probably more significantly is going to be increase the number of GME sites here in the region, because as you guys know, the most potent predictor of where a physician will practice is actually where they did their residency, not where they did their medical school. But Dean Ramsey said by increasing the size of our medical school, we can take a step to meeting those workforce needs. He wanted 4-year training at all WWAMI sites, okay? This goes step in step with trying to increase the workforce, because we can only handle so many here at Seattle. So if we want to increase the size of our class, we need to be able to offer the classes all throughout the region. This is going to end up being a major challenge/opportunity for this school. That's going to be a big deal. And then in 2009, during our LCME accreditation cycle, they highlighted several of our strengths, but also many of our weaknesses, and he wanted those weaknesses taken care of. So the strengths they came up with, and I've already alluded to a few of those, but the main one is our diversity of our clinical offerings. So as I mentioned before, you could do family medicine in rural Wyoming, and then you could come here and do trauma surgery in Harborview. And there aren't too many medical schools across the country that you can get such a tremendous diversity of experiences there. So that was one of them. The other thing that the LCME said that we did particularly well in comparison with other medical schools was our mentoring program and the college program. So what this is there's a group of approximately 10 medical students that have a college mentor in their first and second year, and they meet every week for a morning. They go over clinical problems, they learn the physical exam, they do all kinds of things to sort of increase their knowledge about medicine. And it's been a tremendous asset for our students because they become very well connected with one clinician and sort of get that feeling of what it is like to be a doctor. So that was one of our strong points. In addition, this introduction to clinical medicine, which again is where you learn physical exam, history taking, all of that. In addition, the small group interactions, which were predominantly in the WWAMI region, not so much in Seattle, were touted as being extremely helpful. Okay, so those were the strengths that the LCME pointed out. The weaknesses, and some of these come from what medical students say, so some of these you need to think about, like poor integration of basic sciences into the clinical curriculum. As far as I know, medical students have been complaining about this since the dawn of time. They don't understand why they need to know biochemistry, but then by the time you get to become a practicing physician, you understand the importance. Okay, so is that really a weakness? I don't know, but we certainly, the LCME was encouraging us to make sure we do lots of case studies so students do see, actually, yes, I see that this biochemistry is going to become important in my career. There was a decline in step 1 scores, okay, and I, like most of you, do not necessarily teach to the boards. However, it is important to understand that these step 1 board scores actually dictate which residencies our graduates can go to. So if you have somebody that wants to go into neurosurgery, if they don't get a good step 1 score, that career field is out for them. Okay, so step 1 scores are important. Medical students, when the best medical students are looking at a variety, or when the best undergraduates are looking at a variety of medical schools, they are going to choose the school where they feel they have the chance of getting the highest board score. So it benefits us as an institution to pay attention to the board scores and help them do the best they can. In addition, I already mentioned this insufficient time for career exploration. So medical students and the LCME agreed with them, felt that it was important that our students had more time than just 1 or 2 months to make up their mind as to what they wanted to do for the rest of their life. In addition, the LCME felt that we had too few opportunities for active learning. So what does that mean? That means not sitting in a room listening to me babble on. It means having your hands on gross organs, thinking about a case in a small group, or in a large group, talking with your neighbor, trying to figure out a problem, and then coming together as a whole large group and solving that problem together. What they wanted people to get away from is just the lecture after lecture after lecture, and they wanted more critical thinking, more reasoning, and less memorization. Okay, and you can see as we go forward in the digital age, when everybody has a smartphone and can look up, the relevant fact, memorization, you need to know where to look, but it becomes less important and more important to be able to actually think about what you're doing. In addition, the LCME felt that our department-based courses, so for example, the pharmacology course, the pulmonary course, the pathology course, actually discouraged collaboration and integration between courses. Whether or not that's true, I don't know, because I feel like I see a lot of integration between the courses as it is. But that was one of the things they pointed out. And then this was a big one, is this inconsistency between what was going on in the WWAMI region and what was going on here in Seattle. And it is a consistent thing that all of the WWAMI students feel that they are at a disadvantage to the people in Seattle, because most of the course directors are here in Seattle. And additionally, the courses didn't even happen at the same time. So the anatomy course and I'm not exactly sure of the timing on this, but I know that one of the anatomy courses at one of the sites ends in January. The other one here doesn't end till May. So students are sitting there with a final exam that never gets a grade until Seattle has taken the exam, because if they drop questions or whatnot. So obviously that creates a lot of stress. It makes it difficult to know who's doing what at what time. So that was a real problem. One of the reasons I think we're undergoing renewal, and one of the things I think we can most improve is this. 5 to 10 years ago, when I was in medical school, which was actually longer than 5 to 10 years ago now, but the classroom was full. Everyone was there every day, and if you missed, you had somebody take notes for you, and it was for, a very good reason. And additionally, the other thing you notice is everybody in this picture is taking notes, okay, probably like most of us did in medical school on a piece of paper. Now, on a good day, i.e. the first day of class, the classroom looks like this. And what you notice is it's all computers. Okay, all of the medical students, I would say there are probably 5 to 10 in each class that still take paper notes. Everybody else is on their computers. They're maybe on your PowerPoint, but they might be on Gmail. They might have just, bought a new jacket on Amazon. Seriously. So, and then another problem is tomorrow our classroom's going to be completely empty. And for those of you that have lectured to the medical students, you know that it is very rare to see that full classroom. Our classroom, when the entire class is there, is full with a few people standing. So when you're standing there and you see half the classroom is empty, that means half the class is not even at your lecture. The reason for that is they record all lectures. The students actually do watch them. They oftentimes watch them at 2 times the speed and try to get through things faster. Okay, but that's a problem. We're spending a lot of resources taking an expert in a field to get them up lecturing in front of a whole group of medical students if it's just a taped thing that they could watch year after year. So I think one of the major reasons for renewal is to get away from that, and you'll see how they plan to do this. Start to get much more activity going on in the classroom and a lot less lecture. So what to do? A whole bunch of people have gotten together and been thinking about this. The bottom line was we need to increase active learning, time when the students are actually using what they have theoretically already learned to think about problems and advance their knowledge. Okay, and whether that's in a lab, a small group, or as a large group, they want to increase active learning and really highlight the clinical relevance. So no longer just ramble on about biochemistry, but really take it to there's this syndrome that results directly from an abnormality here. In addition, we talked about this, they wanted in the new curriculum increased clinical time for electives. They want the 4 years across WWAMI to increase the number of physicians, and they want to come up with a way to ensure consistency, which this is going to be a tough one because we are actually scattered across 3 time zones, which makes it even more difficult. So the goal, and many of you have probably seen this around the university, it's kind of posted up several different places. This is the fabric of the University of Washington School of Medicine curriculum. The idea being that here you've got the W, where we have our biggest priorities, that we have a foundation strong in medical science. We have WWAMI down here at the bottom. Patient care is obviously a pillar. The advanced clinical skills, and then going on into this exploration and career focus. But as a student wanders through that W, they weave in and out of all the other things that we as a school hold dear. So things like primary care, health equity, ethics, lifelong learning, discovery. Okay, so this is sort of the ultimate goal, but obviously this does not a curriculum make. So what are the nuts and bolts? How do we get from where we want to be, where we are, to where we want to be? Form a committee is definitely the answer here. And while it was not the UN, which is what's pictured here, hundreds of faculty and students were actually involved across the entire WWAMI region in defining what were the most important things in the new curriculum. This has been going on since 2009, so that's a long time that we've been talking about this. The initial results is everybody wanted a reduced basic science curriculum. They felt that 2 years was just putting us at too long because it made those other 2 years we couldn't fit in everything that we needed to do. So obviously, if you shorten the basic science curriculum, you either cram it into less time or you cover less material. So what the charge has been is everybody needs to reevaluate what they're teaching in the basic sciences and come up with what's absolutely critically important and highlight it there, and then hopefully revisit it later on in the clinical curriculum. They decided to do this by integrating the entire first months of medical school, the basic science curriculum, into blocks and threads, and I'll get into that in a little bit here. They want increased step 1 board study time and increased time for clinical electives, so that takes away from those initial 2 years of medical school. In addition, they wanted a transition to residency course. They wanted a course at the very end of medical school that took everybody going into a surgical subspecialty. Come take this course and you're going to learn how to tie knots, you're going to learn how to do whatever it is that surgeons do. Same with medicine, you might go and you might focus on pharmacological interactions now that you really understand more of what's going on. And then theoretically for pathology, and I'm lumping pathology both AP and CP, we could use this time, if we had somebody going into this, use it as a time to go over basic lab medicine principles, to go over basic histology that you need to know. So when our graduates go off to their program, they are the shining stars in their next residency program. And then finally, there was this formation of intersessions, which I'll talk about here in a little bit. So this was the basic block of the new curriculum. And again, I know this is difficult to read, so I'll walk you through it. But all of this would be the start of medical school. And this would be, there's this foundations block, which runs through here with all the blue to this point. Okay, so it is about 18 months of time, 15 months of class time. That's down from 2 years of time, which was actually about 18 months of class time. Then you can see here, we've got our required clerkships, which really don't change much, and then increased time for that career exploration. That was the big difference. So how were they going to split this up? So clearly they formed more committees, but they came up with 3 main components of the curriculum. The first being the scientific foundations, all right, and so that becomes those first 15 to 18 months. Then you have the patient care phase, so that is what was traditionally 3rd year, where you're looking at the required clinical clerkships. And then finally, the last phase being the career exploration and focus, where you had more time to figure out what you wanted to do. So I'm going to talk about the foundations, what happened in the foundations, because I'm sure many of you saw a lot of the chatter that was going on about that. And clearly that's where we as pathology currently sit. It is not where I hope that we exclusively sit, and we'll get into that here in a bit. So Dr. Montine and also Dr. Steiner were in charge of this foundations committee, and many of you saw the RFP, or the request for proposals, for your idea on the foundations curriculum. There were 35 proposals that were received, and the basic tenets were on your proposal. You needed to offer compelling classroom experiences, so lots and lots of active learning, but a lot less lecture, all right? You need to have interdisciplinary courses where you're really integrating things instead of keeping everybody in their own little silo. There had to be one class at one time across the region. This was the way to sort of standardize everything. So if they were learning about doing the cardiovascular system here in Seattle, they had better be doing it in both Alaska and Wyoming as well, so that everybody got tested at the same time, everybody took each course at the same time, which becomes challenging when you start thinking about these different universities we're affiliated with. Some are on semesters, some are on quarters. It actually causes problems. And then integrated testing. They wanted the testing the same all across the curriculum. This is the new curriculum right now. Again, I know you can't read it, so I will walk you through it. They have divided it into 7 blocks, which run vertically, and then several threads, which we'll talk about, which run horizontally through the curriculum. The first block, here you can see, is the molecular and cellular basis of disease. Okay, and the idea being that you have things like physiology, biochemistry, some very basic anatomy, all focused in on there. Then you have the invaders and defenders course, which is not just bugs and drugs, as it sounds, but really how the body reacts to this. Wound healing goes in there. How a diabetic becomes immunosuppressed, all those things. Then you have the circulatory systems. So they took the urinary system, cardiovascular system, and respiratory system and said those are all part of one giant circulatory system, and we want you to integrate those 3 so that when you're studying hypertension, you're studying what the kidney does, the heart does, how it affects the lung, all together. All right. Then you have the blood and cancer block, which was hematology and cancer, and that's general principles of cancer. Energetics and homeostasis, which is primarily what was the gut course and the endocrine course, but you can see how you can start to mold these things together more. The students will have a summer experience, which includes some scholarly activity, and then on to mind, brain, and behavior, which is sort of neurology, neuropathology, and psychiatry all blended together, as well as head and neck anatomy. And then life cycle and reproduction to finish off with. And then you can see they will have this transition to clerkships, which gives them time to study for step 1, finish their scholarly activities, and get ready for their clerkships. So then this is a pretty typical, it is like a 3rd year, it's just not in the 3rd year anymore. So it starts in March of what would have been the 2nd year. And then you have additional electives here, which is not, I'm not going to spend a huge amount of time talking about that. But the key is there's going to be much more time for medical students to do electives to figure out what they want to do. This is going to benefit us. This gives us a chance to say, do a pathology rotation, spend some time in lab med, spend some time here in pathology, come see what we really do, okay? And then they go on. So, looking across this, you hear I did not show you a pathology course anywhere in here. Well, pathology and histology are a thread, as is anatomy and pharmacology. Okay, there are 3 big threads. So histo and path are together, and lab medicine, anatomy, and then pharmacology. So they are talked about in all of the blocks, but they are not their own course. All right. In addition, there are themes. And I mention these just so you have, when you hear people talking about threads or themes, you'll understand what they're talking about. The themes are things that we hold as crucial that we teach our medical students, but there's not necessarily a course about it, and it needs to be weaved throughout the entire curriculum. Things like health equity, communication, lifelong learning, things like that. So there are people in charge of the blocks, people in charge of the threads, people in charge of the themes, and we're all trying to figure out how to present this as one. So a week in the life of a medical student actually is quite different than probably what it was for a lot of you, and that they have increased the amount of time for personal study and for preparing for class ahead of time, which becomes critical when in-class is going to be shifted away from lecture and towards active learning. So I will talk about that here in a bit. But what happens is 4 days a week for 4 hours, the medical students will be in class, okay? The mornings then will either be free for study or they'll have their college morning. And then 1 day a week, here Wednesday, they will spend the entire day doing their clinical experience off with a primary care physician, learning how to take histories and whatnot. So when does this all start? It starts in September of this year, which is dangerously close considering these courses are not complete yet. We're not ready to go live. So we figure that it takes 9 months to make an incredible living being. We can pull this off. We're going to be able to do it. It's just a curriculum, okay? All right, so what does this mean for us? This does have lots of good things about it, okay, and I'll go into some of those here in a little bit. It also presents major challenges. There's less dedicated my course time, okay, and I'll show you the current second year course, but pathology right now is the single largest course in the medical school. We get more hours of face time than anybody else, all right? That's gone, all right? It's gone for everybody, even the cardiovascular system. They get much less time with the students. So the worry for us is, are we going to be even less visible than we already are? All right, if people aren't seeing pathologists and laboratorians in the first 2 years, they're going to have no chance of knowing what we do, which means they won't go into pathology. All right. So the second thing is, are pathologists going to teach pathology? I can't tell you how many times I've had a clinician say to me, I can teach that, don't worry about it. Well, no, you want pathologists teaching pathology. All right. So we talked about less face time with our students, which means there's not going to be a lot of time, so you've got to actually make the most you can of the time you do have. And I think we all know that when you're actively engaged in doing something, that's when you're learning the most. So we're going to need to shift towards active learning. And a lot less lecture time, which is a major problem. I can deliver a great, the pathology course now, it is lecture after lecture after lecture, and we continually get high marks for it. Okay, we know how to lecture, we've done it, and we do it well. Well, that's all gone. All right, so we're going to have to change the way we do things. But the key thing with lecture's an easy way to efficiently deliver the material that you think is the most important. So how are we going to do that when we don't have lecture? Well, you're thinking, what's good about that? That sounds pretty bleak. All right, well, what's good about it is we are going to have more time to do active learning and integrated learning, and especially a lot of case-based learning. And I think where this can really be an amazing increase in the amount of time is with lab medicine. As you guys know, we currently, in the current pathology course, do about, well, excluding hemepath, we do about 5 to 7 hours. With hemepath, there's more. I think in this new curriculum with case-based learning presents the opportunity, if we seize it, to really engage with these students and show them what we do and what you do in lab med, as Dan so aptly pointed out that I'm not CP boarded. All right, but, and this is a big but, we get to do the active learning, but we still want our students to know what's important. And so as many of you have heard, medical school is like drinking from a fire hose. We've got to find efficient ways to tell them throughout all of the forest, this is what's really important for you to know. So in the past, with modern medical education, it was lecture. That's all going to change. So here's our current second year curriculum, and what you notice is that large yellow stripe at the top of the course, of the top of the curriculum, that was all pathology, and that included lab medicine as well. Now there is no pathology course, all right? And it is critically important that we, both the AP department and the lab medicine department, come together and make sure we still show up in this new curriculum, all right? So we know we're going to do active learning. We know we want our students to know what's truly important. How have we done this in the past? We all own one of these, all right? It's a fabulous book. And I still tell my students, you need to be reading Robbins, okay? And they still look at me, and they look at me and they say, okay, Dr. Rendi, and not a single one of them cracks open the book, all right? The new generation of students, and I don't understand this, but they do not read textbooks. They will read anything you give to them on a computer, but they will not read a textbook, all right, which is causing a huge problem. And Elsevier, who publishes Robbins, as well as all of the other publishers, have noticed this, and it's coming to crisis mode because students are getting all their information off Google. So what we need are additional resources other than textbooks or paired with textbooks, and I'm going to show you something that I'm trying to develop that is paired with Robbins, that will allow us to decrease lecture time but still get our students to know what they need to know. So I'm quickly going to go through this before we get back into more ideas. This is one of the things that I'm planning on doing so that our students have somewhere to turn so they know what they need to know about pathology. So this is an electronic web-based module system I'm developing. It's called Pocket Path. I've had lots of help with it, which I'll get to at the end. But what it is it's a website, and it works on iPhones all the way up to desktops. And you can go on there and you can see here, you can click general pathology or systemic pathology, click on systemic pathology, and you can see all the different areas of systemic pathology. So you can click on whatever you want. In this case, chose cardiovascular pathology, and you can see numerous topics over here that they can click on and go to. But when they click on a topic, this is about what it looks like. And I know you can't read it, it's just a screenshot. And anybody that actually wants to see the website in action, I'm happy to take you through it after this. But the idea being that there are 4 main boxes for each major entity. And what we put in those boxes are the things that we think every physician needs to know, whether it's for the boards or more importantly for practicing good medicine. We put that in those 4 boxes in a very concise way. This is what you really have to know about this. In addition, you can see there are 2 pictures there. The 2 pictures oftentimes are a gross and a micro, like they are here, but they could be a physical exam finding and a gross, or they could be an x-ray and a gross, or whatever it might be. But they can click on that, it'll pop up, and this is actually an image from Robbins. So we have paired with Robbins in making this. And they pull this up, they've got the figure legend from Robbins, and then we can also put in additional things. Make sure you look at this, in this case, the thin left ventricular wall, or here, the hypertrophic cardiomyocytes with the fibrosis in between the cardiomyocytes. So they can flip back and forth through there, they can zoom in and out. They're extremely high quality photos because they're the photos that are published in Robbins. So actually, what we are in a way doing is tricking our students into reading Robbins, okay? In addition, there is a Seminal Papers. They can click on this. This is for the people that want to go much more in depth. They can go and they can click and it'll go directly to a copy of that paper. So, and these papers are chosen by a group of us, we think this is important, and these will be updated. In addition, you can see this extended reading. And this is where the pairing with Elsevier becomes really cool, because they can click on that and it will take them instantly into Robbins to the section where they are. So if they want to, they can go in and actually read the text that Dr. Alpers wrote, if it were on the kidney, okay? What the students like the best is we have test review questions that are associated with all of these topics. So here is a very typical board style question. They read through a clinical scenario. There are the answers. They can decide what they think the answer is. Then they can click on show the answer, pull up the answer with a big explanation, talks about it, which the students love. And it's obviously a good way for them to get ready for the multiple choice tests they have to take. In addition, this is just a strip off the top of the website. You can see here, there's a test review button, which when it's fully operational, they'll be able to click on that and say, give me 100 cardiovascular questions, or give me 250 random questions in pathology. So they can just take the questions and prepare for whatever exam they're taking. So here's just a few more examples of some of the other pages. Each page is its own little thing. The boxes are not always the same because, dealing with general principles like hypertrophy and hyperplasia is obviously different than dilated cardiomyopathy. So they have different boxes, different highlighted points. Here's just another one looking at a cancer one, so you can see what that is. So my intent with this is to tell the students, if they're coming to review a thing on urothelial carcinoma, that's what we're going to be talking about the next day in class. They are going to be expected to work their way through this module, understand the basics, so then they can come in and there can be a clinician and a pathologist. We can have a gross, organ in front of us, or they can come into lab and look at organs. We can spend the time in class really using the expertise of our clinicians, not so much lecturing the same material over and over. So this is one thing. I'll quickly show you some data on this. We've tested it on our current medical students, found that it did improve test scores between a pre-test and a post-test, but that's probably just because they were interested in looking at the new toy. So I don't put much stock in that. But we found that the students will use it. So approximately 90%, and we have replicated this in several classes now, it's always right around 90% are interested in using the electric modules. The other 10% are not. The students do think it can replace some of the lecture time. So that's probably good because that's what's going to have to happen if we're going to go where we need to go. And then this was interesting to us. We sort of felt like they would be using desktops to do this, maybe laptops, but really what they wanted on is on their phone. Okay, and so we had to recode the whole website so it's very easy to read on their phone, but the students love it. They sit on the bus coming in here and they go through pathology, which what could be better than that, all right? Okay, so what we've learned about this is that the modules they are able to deliver the important material. They like it. Maybe their test scores improve. I didn't show you the data on this, but they can get them ready for a lab session. We did this with the cardiovascular lab. We had them basically only have access to the modules before they came to the lab, and that it may be able to replace lecture. What did the students want? All mobile devices. They want auditory clips embedded into it, which may be part 2. So they want to click on a button and hear me walk them through it. And I guess when I first did it, I'm a visual learner, as probably most pathologists are, so I didn't think of that, but they want to be able to hear it. And then they love the test questions. So now they've got this sort of broad syllabus where basically, I mean, it's funny, when I'm writing the modules, I'm sitting there with Robbins open. I'm reading Robbins, translating it into those 4 boxes. So hopefully our students are reading a little bit more than maybe they currently are. So now we've got time in class, and this is where we are really going to shine if we can do this right. Okay, what do we need to do? We need to promote active learning, and we need these students to see what we really do. Because if they see what we actually do, they're going to want to go into our specialty, because what we do is cool, right? But most third-year medical students, I'd say most residents, and arguably many clinicians have no idea what we do on a day-to-day basis, all right? So what we want to use class time in the AP world, we want to be looking at gross organs, holding, feeling, touching. You know, that sticks in your mind. All of you remember that from medical school. We want them to be experiencing the delight that this woman is seeing as she looks through the microscope. However, the University of Washington got rid of all their microscopes, so it will be digital pathology, all right? But we do have good digital pathology options for our students to use. We want them to be in real and in mock tumor boards to see how does a pathologist really interact with their clinicians. We have very close relationships with our clinicians, and we want them to see that. We want them to see how histology and all of this stuff that they're learning is actually showing up in a clinical realm. And finally, this is one idea I've had, is we want to have pathologists on rounds, okay? And so that Introduction to Clinical Medicine course that I talked to you about, one of the things they do is in a group of 10 to 12 students with their mentor, they go out into the hospital, all right? And they just see whatever patients there are. Say they go in to see a Crohn's patient. How amazing would it be to have a pathologist there? You know, so when you came out of the room, you had a little iPad with the histologic, the gross findings, say, hey, remember those ulcers? Like, this is what their bowel actually looks like. This is why they're so uncomfortable and so miserable. And how well that could help our students really put the pathology into context with what's going on in the clinic. Now, you may say, and it's true, that's going to take a lot of time. But how many of you would you rather spend 2 hours lecturing to a half to 3/4 empty lecture? Or would you rather spend 2 hours going on rounds talking about all the cool stuff you see in the hospital with a group of students? So it may have benefits for us as educators as well, because that's fun. You know, we've got digital pathology. The great thing about our thread is it's histology and pathology. As most of you know, they take histology at the beginning of the first year, then they get into pathology in second year, and they have no recollection of what the normal looks like. So hopefully in the new curriculum, we'll be able to say, this is what normal bowel looks like. Now let's look at what neoplastic bowel looks like and try to keep that memory a little more fresh. The problem is that most medical students still think this is what a pathologist does. Now, we do this, all right? And it's incredibly, we learn a tremendous amount from it, but we need to make sure that that's not all they think we do. And what do we do to help this impression? We show them, gross organs of heart attacks, we show them the histologic features, and we show them Robbins. This still needs to be there. I am not advocating that that be gone. But they also need to know how a renal biopsy gets read. They need to know what a frozen section is. They need to know, how pathologists are operating on a daily basis. By the same token, what most medical students think every laboratorian does, they have no idea. They think it's a black box where stuff goes in, it somehow comes out, and it's all highlighted with their critical value labels, okay? We need to change that. All right? We need to make sure they know that pathology is at the point of care, that all these clinical decisions are being made on what we say. We need them to understand what the genetics lab is doing. We need them to understand how the microbiology lab functions, what transfusion medicine is, what cytology in a frozen section is, cytogenetics, chemistry. I mean, how many medical students know that there are physicians whose specialty is chemistry? But how important is it? It's so important in all the values that they're always looking at. We need them to know how next-gen sequencing and PCR affects what chemotherapy their patient's going to get. They need to know what informatics is and how it's going to affect as that becomes more and more important. We've got to teach these students to do this. We've got to help them understand about resource utilization, because obviously as we move into the ACO era and needing to save money, the lab is a major area where we don't want people just wasting money without knowing what they're doing. So how do we do this? Okay, we need to collaborate with our clinicians. We need to do mock tumor boards, and we need to get patients into real tumor boards. I do this already in the pathology course. We bring in the breast surgeons, medical oncologists, radiation oncologists, pathologists and radiologists, and we do a mock tumor board to show them how we all interact, okay? We need to do small groups where you have a pathologist and a clinician that are discussing the pathology and have them see how many times the clinician actually needs to turn to the pathologist for something. So say you have a patient with alcoholic liver disease. Think of how many biopsies, if they go on to a transplant, how many lab tests, how many the explant. Let them see how many times the clinician actually has to depend upon the pathologist for what to do next, okay? So what we need to do is we need to incorporate as many scenarios where pathology is central to what's going on so that the students can understand. And my thought is also if they understand the pathology, then they're going to be able to better treat their patients because they're going to know what's going on. So we need to get in every single part of the curriculum, and this is where I think lab medicine has the opportunity to really increase its presence. Okay, we can do case scenarios where you have transfusion medicine doing a massive OB transfusion. We can put that in the repro part, talking about what happens there. When they're doing rheumatology, get the immunologist in the room talking about ANCAs. It's also a great time to talk about resource utilization. In addition to that, you have the pharmacologist is talking about different antibiotic choices. Have the microbiologist come in and to discuss how does this actually happen? How do we determine the sensitivities? Get a molecular virologist with a pregnant patient that has possible H1N1 flu. Get a molecular geneticist to come in with a metastatic carcinoma that is no longer responding to anything, and have them see what Oncoplex can do for them and identify new mutations that may be targetable. Have a patient with high triglycerides that has an abnormal sodium result. Talk to the medical students about what that means and why it may be abnormal. So there's thousands of case opportunities to do this. We just need to be able to find the time and the space to do it. We talked about the pathologists on rounds already. We also want to push to have required conferences led by pathologists in the clinical years. As you know, I mean, as things get more and more busy, it's less and less likely that people have time, you know, especially in surgery, to come down and follow their frozen section specimen and see what's going on. But we need to encourage our students to do that. We need, you know, to have a rotation on the surgery thing like they do at the VA, where you bring in gross organs that they took out, they were with the surgeon that took them out that week, have them come down and look at those organs with the pathologist and see what was happening in those patients. You know, it's an incredible learning opportunity, and it can be in every single specialty. There's probably not a single case in this hospital that you can't somehow find a way that we're connected to. Simulate critical frozen sections, help them to understand, you know, if they're looking at a brain lesion, if we say it's lymphoma or we say it's GBM, that's the difference between closing the patient and doing a massive resection. You know, help them to understand that. In addition, Dr. Fligner runs this fantastic autopsy course right now. I don't know if all of you know this, but it's an elective right now, and she has students come in, they observe an autopsy, they go to some lectures about, you know, how to talk about death, how to ask for an autopsy, how to write a death certificate, which is extremely important for clinicians. Then they go to the M&M conferences and see that all presented and talked about as it all comes together. This has been an enormous learning opportunity for our medical students thus far. In the new curriculum, I want this to be a required part of the pathology thread. We will have 100 students here in Seattle. I think every single one of them could benefit from coming, and I mean, the amount of medicine you learn right then and there is striking. I want to know your guys' ideas, you know? As you know, without the lab, they're just guessing. How many more ways can we help them understand this? So here is my view. You know, this is the traditional view of the hospital. They always put anatomic pathology in the lab in the basement, right? Well, I prefer to think of that as the foundation of the entire hospital, because without us, they wouldn't know what they were doing. However, what we want to do now is we need to be up everywhere. And you know, this goes for how CAP's new initiative with the new pathologist. We've got to be up in and being really visible among all our clinical colleagues. We also need to teach our medical students these same things, how important we are to the actual running of the hospital. So the bottom line is, in our new curriculum, we've got to show off all that we do. We have a fantastic opportunity right now to totally redirect the way we do this. Okay, and so we're going to seize it, and I hope that many of you will want to become involved in this and really partner to make this a premier place to learn pathology and laboratory medicine. So in our new curriculum, if the sun is pathology and lab medicine, we want it scattered throughout the entire curriculum. Everywhere a medical student looks, from the day they walk in to the day they leave, they are seeing what we do, seeing how critical it is to understand the basis of medicine. So I don't know if you can see this, but I thought this was cute. We want them not only to love pathology, but they want to realize how important it is. Okay? So I'd like to acknowledge Dr. Michael Ryan. So he is the Dean of Curriculum, and he has helped, you know, he has been integrally involved in this whole thing, but he also helped me put this talk together by giving me many of the details about the new curriculum and the hows and whys it all began. And then with Pocket Path, there are several of us in the Path department working on it. So Dr. Susie Dinsis, and then is helping drive Pocket Path. Jonathan Henriksen, for those of you who don't know him, is an IT or computer guy, and he's fantastic. He's done a lot of the coding on the website, a lot of help from a couple undergrads and graduate students working on trying to get all of that inputted into Pocket Path. So, any questions?
So, this program is students are first. So, how is it going to help us as faculty? We engineer our courses, the time commitment, which we're not paid for. We have clinical duties and other duties that basically now consume all of our time. Where is I mean, and it's not gonna work without us.
No.
And so how's the dean gonna help us?
The question.
Right. So the question is, how is the dean going to help the faculty sort of reinvent all of their courses and come up with all of this, which takes a ton of time, and what resources? So the School of Medicine, they have produced additional funding for some people. Right now, the funding is directed at the people trying to figure out which block goes first, when does it happen, who's in charge of it. I am hopeful that that is going to trickle down as we get into the nuts and bolts of who's teaching what when. Unfortunately, there is never enough money to help everybody get the time off service. But I do think there is a general recognition across the school that there is an enormous amount of time needed to do what I've just talked about. And that if you're going to have a quality curriculum, you've got to give off service time for people to do it.
Because, I mean, it's one issue to carve out 2 weeks of your year to devote to teaching. But to say that my teaching is now going to be spread over a number of weeks or months, given that our schedules, what they are, is going to make it extremely difficult.
So the question is, you know, if you have teaching in 2 weeks versus all throughout the curriculum. And I do think that, the way things will go is not any one subject will be spread out all across the curriculum. I do think there will be point times when you show up. Now, it may be 2 days here and 3 days there, but it's not going to be every single day for 8 months. But I hear you. I do hear you. I mean, I know my job next year is going to be incredibly busy, basically teaching pathology every day. But the dean has also provided some support for that.